Ravi, I think you're live now. Ravi, good to go.
Very good evening, everyone, and welcome to No Thrombosis program. No Thrombosis program. Today we are on 40 it for No Thrombosis. It is a really proud moment for us. The almost 44 program we have conducted, and that is all because of the Hiremat sir supports and all our delegates and faculties, as well as our moderator Prabhakar sir, Girish sir supports. We have completed almost 44 program today. At the same time, we have also received, the best, most engaging scientific platform award from by any pharma company by Sims Healthcare Excellence Award. So, I'm very proud and very to introduce our today's course directors, none other than Girish Hiremat sir. So, Dr. Girish Hiremat sir is the director and cath lab of Ruby Hall, Pune, and the sir was the president of CSI during in 2017. Is also convener in National International Council of India at CSI 2004 to 6, and proprietor intervention cardiologist, and has given live courses across the globe. Though coronary interventionals at the heart, he equally adapt at the peripheral arteries intervention, leg, cataract, and as well as aorta, and participated in some of the groundbreaking trials. So, sir was associated since the beginning of No Thrombosis. No Thrombosis is the childbirth of Dr. Hiremat. So once again, from behalf of, I want to welcome to Dr. Girish Hiremat sir. And our second or first is Dr. Girish Nosundani sir. He is the director in cath lab and senior interventional cardiologist from Apollo Hospital from Bangalore. He performed more than 4,000 angiograms to femoral and radial and alveolar approach. As well, he is the first cardiologist to implant, absorb your stent in sectors. And also he is the first cardiologist to implant MRI compatible ASCAD system in the state of Karnataka, and first cardiologist to implant tapering coronary stent in the state of Karnataka. So once again, from behalf of Emcure, I welcome to Dr. Girish Nosundani sir, and our most beloved moderator, Dr. D. Prabhakar sir. Dr. D. Prabhakar sir is the treasurer of CSI 2022 from Chennai. Dr. Prabhakar is senior consultant interventional cardiologist associated with Apollo First Med Hospital and Ashwin Clinic, Chennai. Sir as assistant professor of cardiology in Madras Medical College, Chennai during 1998 to 2002. Sir in many international and national conferences as faculty, as well as he's published many articles in reputed journals, and also many landmark trials in lower work as a principal investigator. So once again, from behalf of Emcure, welcome Prabhakar sir for this program. And today's speaker, Dr. Sajid Kishan. He is an interventional cardiologist from GSL Hospital, Rajahmundry. Welcome, Dr. Sajid Kishan, for today's program. Second speaker is Dr. Rahul D. Agarwal, sir. He is the interventional cardiologist, from Andhra Hospital from MRC Ahmednagar. So, from behalf of Emcure, I welcome to Dr. Rahul Agarwal, sir, for today's program. Welcome, sir. Welcome, Rahul, sir. So today's our agenda. The first case will be presented by Dr. Sajid Kishan. He is from Rajahmundry, and second case will be presented by Dr. Rahul D. Agarwal from Ahmednagar. So with this, I will hand over the sessions to our Dr. Girish Hiremat sir. Sir, over to you, sir.
So good evening, everybody. Mr. Ravi, we are ready to go. Are we?
Yes.
Yes. So we will request Dr. Sajid Krishna to give his presentation. Yes. Then we'll have Dr. Rahul Agarwal from Nagar. And then we have one more slot left. If Dr. Prabhakar or Dr. Girish wants to present, they could go ahead. Otherwise, I have a case ready as a third option.
I think we should put the one that you put on the WhatsApp Academy last couple of days back.
It's too. I don't think I am ready with that, but let me just, by the time 1 hour goes in first two presentations.
I don't think it's fine, sir. Nothing is fine. I think your cases always evoke a lot of interest.
Let's see.
Let's see what Sajid has to say, sir.
Yes, Sajid, can we request you to present your case, Sajid?
Yes.
So, Sajid, you are in which city?
I am practicing in rural Rajahmundry, sir, in a place called Rajanagaram.
Rajahmundry.
Yes, sir.
This is in
In,
Mysore, Karnataka?
Coastal Andhra, sir.
Andhra.
Yes, sir.
Okay.
So, good evening, everyone. Good evening, Hiremat, sir. Good evening, Prabhakar, sir, and all the listeners. So, I'm Dr. G. Sajid Kishan. I am a practicing cardiologist from Rajahmundry, and I practice in GSL Medical College, Rajanagaram. It's a rural part of Rajahmundry. And my topic for discussion is catheter-directed thrombolysis and peripheral vascular interventions when affordability impedes advances. So first of all, warm greetings from our coastal Andhra, and I thank the Emcure team for giving me this opportunity to present in front of stalwarts like Hiremat sir. Once when Emcure team is approached, I didn't have any interesting cases to present, but still any case in cardiology is of interest, and there is nothing like an uninteresting case. So I thought I'll present a topic which is less discussed, that is catheter-directed thrombolysis. So me practicing in a rural part of India, the problem with interventional cardiology is, despite all the advances, always the problem is economic hindrance, and because of that, we are not able to completely rely on the latest advancements. And cardiology treatment is heavily reliant on government welfare schemes. So that's why we have difficulty in doing image-guided procedures and costly hardware and catheters and so on. So coming to my topic, catheter-directed thrombolysis and introduction, it's a treatment modality in acute and subacute occlusions of the lower extremity arteries having salvageable limb ischemia, which are class 1 and class 2A. It's an adjuvant therapy in endovascular interventions for chronic occlusions, and also in many studies involving catheter-directed thrombolysis, we have even class 2B ischemia where catheter-directed thrombolysis is performed, and the main limiting factor is major bleeding complications that can occur. So this was the classification proposed by the style investigators in 1996, where category 1 is viable limb, category 2 is a threatened limb, 2A is marginally threatened, and 2B is immediately threatened, and 3 is irreversible disease. So class 3, normally we go for amputation or any surgery, salvage surgery, and 1 and 2A we normally consider catheter-directed thrombolysis. And 2B is normally surgery that is done.
I'm in a conference just now, but you're coming tomorrow, right?
So, the main limitation with catheter-directed thrombolysis is that there are large variation in treatment protocols.
We are ready for you.
Have been conducted, and the techniques and the regimens are heterogeneous. And to this day, there is no consensus on the optimal fibrinolytic agent or dose regimens to use. And there's no proper literature on usage of STK and the protocols involved. So coming to my case is a 29-year-old male patient. He's a lorry driver. He's a heavy smoker, alcoholic. He came with complaints of pain and swelling in the left lower limb since 4 days and decreased sensation of the left foot since last 2 days. So on examination, vitals were stable. Local examination of the left lower limb showed tenderness below the knee. Sensations decreased over the ankle joint and the foot. Peripheral pulses below the femoral were all absent. Left lower limb temperature was colder than the right. Discoloration of the skin was present on the dorsum of the foot. And rest of the systemic examination was normal. Investigations, the routine blood investigations were within normal limits. ECG echo was normal. Virals were non-reactive. Arterial Doppler showed long segment left iliac and popliteal artery thrombus and no flow in tibial and below knee arteries. And a CT angiogram of the left lower limb showed complete luminal thrombus in the left common iliac, internal and external iliac, distal SFA, popliteal and distal ATA. There was normal contrast of pacification to the right side. So the diagnosis was acute thrombotic limb ischemia, category 2B. So the two options for me was surgery, open thromboembolectomy versus endovascular therapy. So the issues were, as told, it was affordability issues. Patients didn't have any government scheme enrolled, and there was also no availability of surgeon at that point of time. But the idea was to save the limb because the person was the sole breadwinner for the family. So all we could do is motivate them for the expense of an angiogram. So we opted to go for an endovascular therapy and went ahead with an angiogram. So this was the peripheral angiogram which was done, which showed occlusion of the left common iliac. So after that, we have taken retrograde puncture of the femur in the contralateral side and used a JR to take the shot, which showed left common iliac total occlusion. Then we crossed that lesion with a thermo wire and did a balloon angioplasty all along the length till the SFA with an 8 mm semi-compliant balloon. So after doing a balloon angioplasty, we found still some significant thrombus in the distal SFA, profunda, and below. So we again went for a balloon angioplasty for the left SFA with an 8 mm balloon. Still, in spite of that, there was very poor flow and there was extensive thrombus burden. So with this thrombus burden, we not getting a good result with balloon angioplasty. We then thought we would go ahead with the catheter directed to the thrombolysis. The patient was a young guy, 29-year-old, so we thought there are no major contraindications for thrombolysis. So CTT was planned. Then again, over here, the problem was affordability issues regarding thrombus infusion catheter, mechanical thrombectomy devices, or thrombus suction catheters. So what we could do is put a simple 5-French pigtail and make small holes and convert it to a multi-site hole catheter for use. So with this, we went ahead. And as such, there were no standard methods for catheter-directed thrombolysis regarding the agent and the dose, but several delivery methods that were described were continuous infusion, bolus, pulse spray, graded infusions, and stepwise infusion. Currently, the simplest and most commonly performed is a continuous infusion. And the most common used agents are altiplase, retiplase, and tenecteplase. And again, the affordability issue comes into part. So we had to take the age-old drug, which is the cheapest of all, streptokinase. So we used injection streptokinase, 1.5 lakh bolus, followed by an injection, continuous infusion of 1 lakh units per hour. I think most of the literature also does not encourage use of STK, but because of affordability issues, this was the only option left for us. So we have started the catheter-directed thrombolysis, and the shot after 16 hours showed some flow improvement, but still there was a remnant thrombus in the distal SFA and the popliteal. So then we again went ahead with thrombolysis for 24 hours. Then after 36 hours, this was the common iliac was fine. The internal iliac, still there was some remnant thrombus, and this was the flow of the distal SFA. Distal SFA was fine. Profunda femoris also, there was some sluggish flow, but it was patent. The popliteal opened up and some residual thrombus in the below. So the procedure went on well. Patient was stable, no bleeding complication, and patient was discharged in antiplatelets and long-term anticoagulation. So this was the limb after a two-week follow-up, and patient was doing well, and his pain is completely reduced. There was a prothrombotic workup planned for the patient after 3 months. So my second case was a 39-year-old male, smoker, non-hypertensive, non-diabetic, referred from CT surgeon himself with complaints of right lower limb pain and ulceration of the great toe since 10 days. His left lower limb pulsations, femorals and popliteals were well felt. DP and PTA were slightly reduced, and right lower limb pulses, only femorals were felt and rest all were absent. And systemic examination was normal. So all the investigations routinely done were normal, and Doppler showed acute thrombus of SFA, popliteal, ATA, PTA, and dorsalis pedis. And the diagnosis was acute limb ischemia. So this patient, in fact, was referred from the CT surgeon himself because of affordability issues. The patient was not even affordable to get a CT done. So we had to again convince him for an angiogram, and patient was directly taken for a conventional angiogram plus revascularization. So again, a contralateral puncture, retrograde puncture was taken of the femoral, and JR was passed, and we've taken a shot. The upper CIA, EIA, and internal iliac were all normal. Proximal SFA was fine. Then there was thrombus, 100% occlusion in the distal SFA. So we have went ahead with a balloon angioplasty with an 8 mm balloon, and result we could get some faint flow. However, there was extensive thrombus burden still present. So again, for the same, this patient also, we applied the same strategy of using a modified infusion catheter and did STK thrombolysis at 1 lakh units per hour continuous for 24 hours. And after 24 hours of STK infusion, this was the flow we could get. We could get a very good flow, complete clearance of thrombus, and a very below knee artery flow also present. Patient was stable post-procedure and discharged on antiplatelets and long-term anticoagulation. So concluding remarks, both cases were not technically challenging ones, but rather economic challenges. Surgery, though a first-line option, was not performed due to cost restraints, and catheter-directed thrombolysis is a safe and a very cost-effective alternative to surgery in acute limb ischemia patients with low risk of bleeding. And some points for discussion. As no good literature is available, I would be welcoming some inputs of experience from stalwarts on STK usage and maximum duration till when it can safely be given, and inputs of experience on cost-effective prothrombotic workup and realistic long-term treatment approaches in these patients with poor socioeconomic strata. Thank you, sir.
Dr. Sajid, very good presentation. Did you do a sort of post establishment of a forward flow workup as to why they got thrombus? I mean, the truck driver probably sits in one place for a long hours, so maybe that could be positional with some kind of thrombotic tendency. But did the evaluation reveal anything positive in these cases?
No, we have just got the routine investigations done, sir, and ECG echo and all, but nothing. It was a thrombotic occlusion, but we could not get a cause. But to go for a more detailed thrombotic workup, the issue was cost. So respectively, we have planned after 3 months to get it done, but we'll have to see how much affordability the patient will be having, sir.
So patient is now on warfarin plus dual antiplatelet.
Dual antiplatelets, yes.
Warfarin aspirin is not enough. I mean, you must have something else in addition to warfarin aspirin.
And clopidogrel, sir, we have put on triple therapy initially. So
yeah, but I'm asking you whether warfarin aspirin is alone. Maybe Dr. Prabhakar or Dr. Girish can help us.
Sajid, actually, very good cases. I think what you have done is an excellent job. I think you have made use of the available resources and salvaged both the limbs. That itself is a great thing. First, I should appreciate you on that. And what Dr. Hiramat sir is asking you is both these patients need a workup on the why they are so thrombophilic. Now, if you're going to do the thrombophilia package, the point with thrombophilia is they have to be done at the initial onset before you give the heparin. Or you have what you say after 3 months, but therein you have to withdraw the anticoagulation and check it up, because all these things are going to interfere with your protein C, protein S, and antithrombin C. Now, that is going to be a very important factor in long-term anticoagulation. Both these days most probably will require long-term anticoagulation. Another thing you have to ask these guys is any family history of this. Because I do have families with antithrombotic and thrombotic episodes. Like I've had a girl who had a pregnancy-induced postpartum pulmonary embolism, thrombolized second day after LSCS because the surgeon said, don't worry, do it, I'm good. Thrombolized, she became all right. And after about 10 years, there's a guy who came to my clinic and said he had a breathlessness, had a pulmonary embolism. I told him by over phone, no, we'll do this. And he said, okay. I was surprised why he was saying okay to me and I told him on the phone. Then it turned out that he was that lady's sister. Then when he went back and looked, it turns out that their father also had a DVT. And this fellow, when I worked him up, he had an antithrombin 3 deficiency. Now he's on long-term anticoagulation. Till 1 year ago, he stopped the treatment and now again he's got a DVT. It was about 2 weeks ago. So you have to be looking at family history also, which works out very well, because long-term anticoagulation is a very interesting aspect that you have to be looking at. Now, as far as this case is concerned, my question is, all these venous thromboembolisms, they are all thrombotic. Antiplatelet agents, what is the role of antiplatelets in that? I'm not very sure about what is the role of antiplatelet agents in these drugs, or is it related to your doing an angioplasty with the balloon? Because to my knowledge, all these cases generally require only anticoagulation.
Because we still think that it could be atherosclerosis and a plaque rupture. Could it
At
be?
28 years?
Yes, sir, because we see a
34
lot
years?
of cases with premature CAD, sir, in our area.
Indeed, I totally agree with you. But in that case, have you done a coronary artery calcium score or shown atherosclerosis anywhere? Because it's most probably a de novo arterial thrombosis clinically. It's a classical case wherein you suspect a congenital problem and you have to do a thrombophilia workup. Atherosclerosis, and mind you, you must also remember, by adding an antiplatelet agent, you are increasing the risk of bleed considerably.
Okay.
I'm sure there is no data on this, but the second point is, why warfarin? Cost-wise, actually warfarin is expensive because you need monitoring. You can probably, the best data is probably with the rivaroxaban 20 milligram. Probably give rivaroxaban 20 milligram, that's going to be cheap and good, because nowadays it costs about 15-20 bucks, you can give it. So I think that will be a reasonable approach on this particular case. As far as the antiplatelet agent, I think you have to be a little cautious on this. I don't think there is any guidance on any deep vein thrombosis being treated with antiplatelet agents, and I don't think there is any data on that. And you have something, please tell us and educate us.
Yes, sir, nothing like that, because the only thing I thought it was associated atherosclerosis, premature atherosclerosis. That's why I put on triple therapy. I thought I'll downgrade and probably do a workup later.
Agreed, Sajid. Sajid, probably your justification for dual thrombotic therapy, in that sense, dual pathway inhibition, as we call it nowadays, with especially a higher dose, not the 2.5 milligram twice a day. Probably because these guys are going to be low risk for bleed. Both your patients are young patients, so they may tolerate it and you will get away with it. But generally, in principle, for a thrombosis of this magnitude, I would expect more of a thrombotic occlusion where an anticoagulation is going to be more beneficial in these group of patients. But antiplatelet, yes, maybe yes. And Dr. Hiramat sir says that what is the role of dual antiplatelet therapy? I think when you add dual antiplatelet therapy, the risk of bleed becomes more. So in that case, if you're thinking of thrombosis, atherothrombotic disease still, I think it's fair enough to give a single antiplatelet agent and antithrombotic with anticoagulation. I think that's a fair enough composition. But as far as the anticoagulation that you have given in the limb, you have done a catheter-directed thrombolysis. What happens? You have crossed and gone below. Now, as a coronary interventionist, would you have thought about going in, putting in a microcatheter there and seeing a flow there, and probably giving in the thrombolytic therapy distal to it? Especially in the first case, not the second case.
No, even the second case, the catheter just looks into the right iliac artery. So maybe it's about a couple of inches into the right iliac artery. Did you try getting into a thrombus and give intralesional, intrathrombotic?
Yes, sir. Yes, so we have actually placed the catheter. We have made multiple side holes and placed it at the lesion itself, sir. But while taking an angiogram, we have pulled back and did an angiogram all along. But the infusion was done exactly at the lesion only. The only reason for the first case I had to pull it a little up is because even profunda was occluded. There was thrombus even in the profunda. So I had to pull it up and place it for some time so that even the profunda gets the STK.
I think finally the profunda was also open, if I remember right.
Yes. It has opened, but still there was slow flow in it.
These cath lab workup, you do on DSA or you do on a regular cine?
On regular only, so we don't use much of DSA owing to the radiation hazards. Otherwise, if it is a chronic occlusion, probably we would have considered a DSA to see for the collateral flow, everything. But for this case, because both were acute, so I had not gone for a DSA as such.
All right. Dr. Girish is around. Any comments from him?
My apologies, sir. I just joined in a little late. I just had to finish a case.
Okay, maybe.
Sir, I'll give you a summary. Girish, sir, I'll give you a short summary. He has presented cases of peripheral arterial occlusion. from the iliac
Mhm.
now. And both the
Okay.
cases he is given catheter-directed streptokinase.
Okay.
And first case was reasonable results, but the patient symptomatically improved. Both limbs were salvaged. Second case,
Fantastic.
the angiographic results also look fantastic. And the two
Dr.
discussions.
Prabhakar, I think we'll take Girish's input, more inputs on the next case, and
Yeah.
not sort of repeat the whole story.
Okay.
Let's go to the next
I think
case.
it's 30 minutes in. Go ahead, sir.
Thank you.
Thank you.
So we are now inviting Dr. Agrawal or Agarwal.
Agrawal, sir. Rahul Agrawal.
But you are spelling it as Ragragra, correct?
RAHULAGRAWAL.
Agrawal. All right. We look forward to your case.
Thank you, sir. Just like my previous colleague, I work in a sort of a semi-rural setup. And for us, the reality of day-to-day practice is government schemes and cost constraints. I think the difference between big cities and the smaller cities come in the financial part. And I present a case of acute dyspnea. A 36-year-old male who had history of fever 3 days for 3 days. History of recent travel to a crowded place present, and he also had history of cough. There was no history of any chest pain. There was no significant past history, no hypertension, no diabetes, no congenital heart disease, and no history of asthma. And he had no history of any provocating factors for DVT, no bed rest, no thigh pain or swelling. He was vaccinated for COVID, and he was not under any treatment for any COVID disease or any tuberculosis in the past. On examination, he had tachycardia and tachypnea and was hypoxic with saturation 91% on room air. Normal blood pressure was present, and everything else in the systemic examination was normal. He is fully conscious oriented. The systemic examination was normal for all practical purposes. He was admitted to ICU. A presumptive diagnosis was kept as a lower respiratory tract infection and query a COVID pneumonia. ECG shows few changes. That's why I got involved into the case. The chest X-ray done was normal. We did echocardiogram on the first day itself after rapid antigen test was done, which was negative for COVID virus. And it showed a dilated right atrium and ventricle, mild tricuspid regurgitation, and a severe pulmonary hypertension with a PA pressure of 70 mm of Hg. So immediately he was suspected to have a pulmonary embolism, and a CT angiogram was done. So this was his ECG done in the ICU. After he had settled down a bit, so tachycardia has settled, but we can see a deep T inversion in the V1 and V2 lids. Other signs, classical signs, are absent. Go for a CT scan. You can see this is a film of the CT scan. I'll show the images later. There is a thrombus in both pulmonary arteries. We can see a large thrombus over here. The dilated RA and RV. The black colored thrombus present in both the pulmonary arteries is seen clearly. In a zoomed up image, we can see that in the peripheral branches, both side thrombus was present. So the CT report we got it at very late hours of the night. We also got his lab done, and which shows a normal complete hemogram. ABG showed mild hypoxia. Other parameters are mostly normal except for a troponin T, which came out to be positive, and a D dimer of a very high value, 8791. So otherwise everything was okay. He was started on basic supportive treatment, and we were gradually deciding his further course of action. Next day early morning, he started deteriorating rapidly, and he developed hypotension requiring noradrenaline support And he also started desaturating, which required a high flow O2 and later a BiPAP. He was given an option for aspiration thrombectomy and shifting to a higher center in Pune or Mumbai, which he refused due to lack of money. So we put him in the government scheme, and decision to thrombolize was taken. So instead of streptokinase, we used urokinase for the patient. He received a complete full dose of urokinase for 12 hours, following which he stabilized remarkably. He became comfortable. There was reduced O2 and ionotropic support, and clinical picture remarkably improved. We were doing close follow-up, and daily echo and everything was being done. On the day 4 of echocardiogram, this was the first echo we done after thrombolysis. It showed a PA pressure of 50, so reduction in PA pressure, and there was no clot. This is on day 4, bedside echocardiography, and we showed a mobile thrombus in the right atrium. It is crossing. It is almost a clot in migration, and a very, very large clot was seen. I'll show it again. This ball, almost a ball of thrombus, big mass of thrombus was seen in the right atrium, right ventricle, almost extending into the pulmonary artery. Surprisingly, he was clinically quite stable at this time. At the time, we had CVTS surgeon available at our campus. We took an opinion and he advised a surgical embolectomy because the patient was young and the thrombus mass was very, very large. It was explained to the patient and the relatives. They were actually not so affording and they refused surgery. We also had a hematologist available, so we took his opinion. We told him that he was already on heparin and had been thrombolized. Still, he insisted on doing a complete thrombofailure profile, so it was sent. Patient refused surgery. So instead of low molecular heparin, we stepped it up with the unfractionated heparin infusion, 1,000 units per hour with APDT monitoring. Venous Doppler was repeated and it showed a right lower limb partial recanalized and fragments seen in the internal iliac and IVC. Some thrombus were present there also. This is a repeat Doppler done later on. Further course, the patient gradually improved with heparin therapy. He echo showed resolution of thrombus. I don't have the images, but he gradually reduced. In the next 48 hours, we stopped the IV heparin and shifted him to oral anticoagulation with rivaroxaban 15 milligram of BID. Day 7, he was moved off all the support, and day 8, we received the thrombophilia profile while he was in the ward. So it showed surprisingly a homocysteine level of greater than 50. A B12 deficiency was also there, and he was a strict vegetarian. Other than that, protein S deficiency was present. Protein C was normal. Factor V leading mutation was absent. ANA negative and ANCA negative. This was a complete ANA blood done on request of a hematologist, and it was negative for almost all the parameters. The homocysteine levels were markedly elevated of greater than 50. The lupus anticoagulation or anticoagulant was absent. Patient was discharged on day 10 on rivaroxaban 15 milligram BD, Homochek BD, and other supportive treatment. He is on regular follow-up, doing remarkably well, mobile, and has resumed his job. He is currently on rivaroxaban. Right lower limb Doppler was done later on after 14 days, which showed a very good resolving thrombus. So thank you. This was my case in short.
Hiramat sir, you are muted.
I was asking, how are you treating his hyperhomocystinemia?
I have started him on homocheck. That is the one I gave. It's a combination of pyridoxine, B12, and folic acid.
Can you tell us what dose is required and how much of that is there in homocheck? I think it's a very small dose that you give in homocheck. So I would probably feel the dose required is much, much more.
Okay.
Dr. Girish, your comments, since we missed you on the first case.
Very. Yes, sir. I also agree. It just depends on how they respond. Normally, there are 2 or 3 bands. 5 milligram folic acid twice daily you can give. Homocheck, or there's another one called NCBM 69. That's what my hematologist prescribes. We wait for about a month and see if the homocysteine levels fall below 20. If it does not, then we tend to double the dose.
Sir, actually, there is only one small study on these homocysteine levels and post and interventions. What happens when you give something? Study is post PCI study where homocysteine levels are high, and that is the dose which is actually given in this homocheck capsule. So apart from that, there is not much of any solid data on giving us a specific dose for homocysteine levels, treating homocysteine levels. And what he is giving is homocheck capsule twice a day. That I think is the standard dose that is recommended in the particular study. I can't get the name of the study offhand. I'll try to get you, which is a post PCI study that was there. Apart from that, there's nothing much on the homocysteine levels. And this particular case, I don't know. I'm not sure about the protein S was deficient, correct?
Protein S was deficient.
Protein S was deficient.
But he was already on heparin. That is the problem.
So you can't really comment on that at this point of time. And what would be your long-term implication on this protein S deficiency? What is your long-term plan for this particular patient?
Dr. Prabhakar, what are you suggesting? Whenever you're suspecting any thrombus anywhere, you pick up a sample and then start working on the case. Is that correct?
Exactly, sir. The first sample, when you do, you send it for the thrombophilia package.
Correct.
Before you
I
give
think
heparin.
all of us must remember that once you treat them with all kind of blood thinners, the reliability of the thrombophilia package goes down.
Yeah.
And then you are struggling for a long time, how long to continue, what should be the dose, and those kind of things. So first pick up a sample, send it for thrombophilia package, and then continue to work on these kind of cases. But anyway, Dr. Agarwal, what is your plan? You think this dose of homocheck 1 OD is going to be adequate, or you would like to try what Dr. Girish suggested?
Yeah, I've already put him on twice a day. And he also received IV B12 where he was hospitalized. I think he received 3 doses of that because vitamin B12 were also coming low in the study. So I corrected that factor what I could. Other than that, I have started it twice daily.
Okay.
I may also increase it. I have not read the literature, but I will increase the dose if the panel suggests. Regarding the long term, what I plan to do is that once he becomes stable, then maybe 3 months later, stop his anticoagulation and again refer him to hematologist and recheck that protein S part, whether it is really there or was it just a heparin effect.
I think it's worthwhile to look for whether it was, non-provoked or a provoked DVT and pulmonary embolism. Means if there's a history of any injury, long travels or dehydration, something like that, then you have a definite cause for it, and at the end of 6 months you may have to stop, need not continue. But if it's a totally unprovoked, no malignancy, then you really need to look up why did he develop such a massive clot burden. And another pulmonary embolism, these people, 50% of them will have another pulmonary embolism in the coming year to 2. So it's not a very innocuous thing. He will need a lot of your attention.
Yeah, definitely. It was a totally unprovoked one. Just that on detailed history, he had a history of travel. But I would not say that he traveled for a very long distance or a long immobilization was there. It was a short travel only. But what I feel ki may be a sort of a post COVID sort of a picture, what I feel. Because CRP levels were elevated even when the rapid antigen test was negative. It could be a post-COVID event. What I feel.
Dr. Agarwal, what Dr. Girish sir is suggesting is very, very important for his long-term outlook. Now, one is you're suspecting COVID, fine. But the point is, if you are going to have a proteinase deficiency that is suspected, it's going to be a little tricky for you to diagnose it later because you have to withdraw the anticoagulation for a period of about 2 weeks and then do the proteinase levels again. And if you find that the proteinase levels are low, then you have to anticoagulation. And that's a very interesting point there also. If you're going to anticoagulate him, there are 2 kinds of anticoagulation long-term that is described. One is with 20 milligrams rivaroxaban, another one is 10 milligram rivaroxaban. Both are described. 20 is supposed to be slightly superior, but 10 is fair enough. What I do is I have patients with protein C, protein S, antithrombin 3 deficiency, 3 different kinds of patients I have. All of them, I tell them exactly what Dr. Girish said. There is a 40 to 50% chance of recurrence, which is very high. So when you have a 40 to 50% chance of recurrence, you explain to them, you don't have to really put them, you explain to them, it's a conscious decision, combined decision that is discussed with the patient. The patient is willing for it, put them on long-term anticoagulation, and they're going to continue it for life.
No, 1 minute, Dr. Prabhakar. Your dose of rivaroxaban, you're suggesting only 10 milligram or 15 milligram?
Sir, the dose recommended during the initial phase, what he has given is for the first 21 days, 15 milligram twice a day.
Absolutely.
After 21 days, it becomes 20 milligram once a day. And rivaroxaban has to be given along with food, not before, after food. Absorption is actually better with food. So you give it after 21 days, you give it for 3 months. After 3 months, if you decide on long-term anticoagulation, there is data for both 20 and 10 milligrams. All my patients I put on 10 milligram, and so far none of them have recurred, except the guy who stopped the anticoagulation.
Yes.
What I feel,
Yes,
considering
yes,
his
yes.
case, he would be better off on lifelong anticoagulation.
The point is, you need some justification on that.
Yeah,
Because
definitely.
to put him on a lifelong anticoagulation, you need some evidence to tell him that he's going to require it. Because if he bleeds, he's going to sue you.
Yeah.
But it's also true that if he gets another pulmonary embolism, even then he's going to sue you. So
Sir, that's why I said it's a combined decision.
So combined decision and correct dose.
Correct,
I would
sir.
probably send all of them on 20 milligram long term, especially young people who are.
Sir, there is enough data on 10 milligrams, sir. It is also a same class of recommendation as 20 milligrams, sir. I'm sure if Agarwal looks into it, he'll be able to get the reference because I have checked up and then put these patients on 10 milligrams. But interestingly, the long-term anticoagulation is really not studied much in the protein C and protein S deficiency category.
Yeah, definitely.
That's
Actually,
interesting
what
point.
I feel, sir, this thrombophilia profile and all workups, we are doing much more nowadays. In the past, not many people were very serious about it. What I feel, it was actually very expensive. The cost has come down nowadays. Still, once the patient becomes better, a lot of them get lost to follow. What I feel.
Yeah, I think in that case, I think to be fair enough to say that if you have an unprovoked pulmonary embolism, discuss with the patient like what Dr. Girish says, and put them on long-term anticoagulation is probably the safest if you can't do a proper thrombophilia workup. That I think is the safest option. But like you say, it has to be a combined decision with the family and this thing. Clearly document the risk of bleed. Because nowadays documentation has become very important. I'm sure Girish would have something to add on this.
No, I see. We have a moral responsibility to do what is scientifically correct. Whatever it costs, whether patient does or not, document on your prescription and tell him this is required. Please go to a government facility if you cannot pay for it and get it done. We try and do it here. If they can't afford it at a private clinic, we'll send them to government place and give a very strong recommendation for letter. Again, the best time to do is probably after 6 months rather than end of 3 months, and having evidence of significant pulmonary hypertension has resolved. Do another venous Doppler. If it permits, get another CT pulmonary angiogram to know that there is no obliteration of the pulmonary vessels. Honeycomb. All that gives you some idea what will be his future vulnerability for a severe pulmonary artery hypertension or a recurrent pulmonary embolism leading to chronic carpulmonary. So I think these are a few things that in a young person you need to follow up with.
I think both Sajid and Agarwal's cases are some kind of a problem wherein you have an unprovoked thrombosis and classical cases of some kind of a thrombophilic milieu that is happening inside. And I
So
think
what will you do? Long-term anticoagulation?
I think so, sir. Unprovoked arterial thrombosis is very, very rare unless there is clear atherosclerosis. And if you have an atherosclerotic thrombotic disease, antiplatelet therapy is going to work. How are you going to differentiate that is a very difficult point to prove. Talking about CRP and COVID, that is another interesting point because you really don't know whether this guy has got COVID. Maybe you could have done the IgM, IgG, but like you said, cost is a major factor in rural India, and getting the test done is also going to be difficult. Better to anticoagulate for 3 months, look at it. And Dr. Girish says echo is going to be fairly simple nowadays. It's going to be easy. There's no pulmonary hypertension. Probably recheck only the protein S at that time because you had the problem only with protein S.
Yeah, I'm doing his echo every month. I'm doing it complimentary for him, and his PA pressure is going down. He's now it's in the mid 40s.
So,
And he
that
had done his
doesn't
doctor
decide
also.
the duration of the anticoagulation. I mean, PA pressure going down is a good news, but doesn't help you to decide how long you should go with anticoagulation. I think all these protein S, etc., are required to decide how long you should continue.
Definitely.
They're going to be long-term risk for individuals.
In the first 6 months after your oral anticoagulation, if there is no worsening of pulmonary hypertension, another recurrent event, probably at the end of 6 months, you can consider stopping it for 15 days after documenting that there is no fresh thrombus in the veins on a DVT. Okay. And do another thorough hemophilia checkup. And if there is absolutely no identifiable cause, then you would probably think it as it's a provoked, or you could say COVID or whatever. If you think there is something abnormal, then automatically it becomes lifelong anticoagulation.
All right. Do we have any third case, or shall I present one case? All right, with everybody's permission, I'll present one case. It's about, what time is it? 8:50. So we have time for one case. Dr. Prabhakar or Dr. Girish, you want to present any case? Because I presented it last time.
you go ahead, sir. Probably next time we'll arrange for something.
All
Yeah,
right.
I wish they had told me in advance. At least a day advance, I would have picked up something. In the meantime, I'll try to cook up. There is one particular data on which anticoagulation interferes with which protein C or protein S. I'll try to fish out that slide by the time you finish your presentation, sir.
No, for next meeting of Emcure, you must show us that. Huh?
Sure, sir. Sure, sir.
All right. So actually, we have this gentleman who had a left main thrombus. His presentation was quite dramatic: intense chest pain, profuse sweating, and gross ST changes. And we sort of took him up to cath lab, and this was what we could see. So some thrombus at the left main proximal area, and distal vessels are quite nice and clean. So this was sort of a 50-ish gentleman with no risk factor, and this is the thing which we would have loved to do imaging, because apart from thrombus, there could be a flap in the left main, which would give a similar presentation. So flows in the LAD appear clearly slow, and you have something going wrong in the left main. So what are the possible options at this stage? You give intracoronary lysis. Dr. Prabhakar or Girish or Dr. Sajid or Dr. Agarwal, anyone could give their opinion. So this was the image that we are seeing in the cath lab. So we lyse or we stent?
Sir, my choice for
I
this.
think, that's.
Go ahead, sir. Go ahead, sir. Girish, sir,
No,
go
no,
ahead.
please don't. I think this is a very dangerous place. If you have a failed thrombosis, it could be catastrophic, but I think it's safer to do a PCR after imaging.
This gentleman was very young, something like late 30s, and had no risk factors. So this was weighing on our mind, and we thought we will give him a lysis. There were some other cases. So this was another case who had an inferior infarction. And on day one after cath lab, we could establish some flow, but a lot of sticky material in the RCA, and we did not stent him. We gave a tirofiban for next 2 days, and this is what you see, reasonably good flow. So no balloon, no aspiration, and just tirofiban could give us this kind of result. So this was at the back of our mind. But then we are dealing with a left main case. This was another case where we have a thrombotic occlusion, thrombotic narrowing of the left main. Again, a very young individual, and a thrombus there. As we were talking with the family, what are our possible options? He had a cardiac arrest. And this is the trouble. And we could not salvage him in this peripheral hospital. So this was another case where we have non-STMI. Patient was reasonably stable, and we had this thrombus at the mouth of the left main. And in this case, there is a lesion in the distality with the extension into circumflex and LAD. So this case was my colleague cardiologist, and he preferred bypass surgery on this right-hand case. And even in both cases were sent for surgery. So this is our case, and blood pressure was borderline. We thought we must have a good flows, and that's why we maintained him on IABP despite a reasonable blood pressure. Then we did a thrombus aspiration, and I don't think you're seeing too much of benefit with thrombus aspiration, though this aspiration could have been done with the guide catheter itself. I mean, it's so close to the thrombus that you probably don't need to put in another aspiration catheter. So we did that, but probably did aspiration with the aspiration catheter also. And these are some of our thrombotic cases. You can see a vein graft. It was 8 or 10-year-old graft, and but short story. And you see how deep we have taken the guide catheter. It is all the way down, almost to the junction of the vein graft with the right coronary artery. So this was taken over balloon protection, like a wire and balloon inflated, and then the catheter was slipped in. And you can see after some good work, we can see a beautiful flow in the venous thrombosis. So these are some things which we don't think of routinely, but thrombus is a ball game. And even if you're about 30, 40 years into cardiology practice, every thrombotic case will teach you something different. So this was totally unexpected. Vein graft, which was occluded and looking so brilliant at the end of this. So this is back to our case. Thrombus aspiration was done. Tirofiban was given in the coronary, and I mean, still whatever was there in the left main, you can still see. Unfortunately, in this lab, we had no imaging facility, but even that would have been of great help to decide whether there is a dissection of the left main. The patient had multiple aspiration, looking slightly better. Thrombus load appears much less in this particular image. And this patient, we thought we'll check after 48 hours of tirofiban heparin combination. And this is how the thrombus looked smaller. Yet, I think imaging would have told us whether to stent or not to stent. But in this cath lab, we had no imaging. I was in a peripheral lab. And so we decided that safer to stent, looking at the location right at the beginning of the left main. So this was a stent. I thought it was in a reasonably good position. This is a close to AP, shallow RAO, and this is a LAO cranial. I use these two angles to make sure that you are in good ostial location, and always have some catheter floating into the aorta. You can see the stent clearly covering the ostium and floating into the aorta. And then it is inflated. You see the waist. You pull back the same balloon, go high on pressure. And so despite taking all this care, this is how we are looking. The orange color is the stent and the blue is the vessel. And we could see something which is going down like this. You can see better here. And this view sort of tells me that we are not at the ostium. I mean, the catheter, the stent is not covering the ostium. I think we are reasonably sure that we have missed the ostium. And as I told you, there was no imaging possible. And we have a very good experience about overall left main stenting. And Dr. Mark Silvestri has been our guiding force in doing more and more left main. So we said we'll go ahead. This is the second time after 48 hours of tirofiban. We decided we'll go ahead with the stenting. We have a reasonable length before the bifurcation, and we thought we will limit ourselves only to left main and not hit the bifurcation and block the origin of the circumflex or LAD for that matter. So our wire is in LAD. We are in a spider view. And this is the deployed stent. And in spider view, it looks good. You can see it looks good, but in LAO cranial view, which was the view in which we actually positioned our stent, the stent seems to have missed the ostium. I think most of you would agree that there is a clear gap between the origin of the left main and the origin of the left main stent. So this was better seen in LAO cranial. So LAO cranial is a view I'm suggesting we should all check again and again for left main ostial stent. You can take a AP cranial also or a shallow RAO cranial to get your stent at the exact left main ostium. So then we we had almost decided we have missed the ostium, and also we had dilated the ostium, believing that we have covered the ostium with a metal, half balloon floating outside to go high on pressure. So we had obviously damaged the left main ostium, and we thought we'll put one more stent in this location. So the flows are looking good at this time. Patient was quite stable, but see here, we are very unhappy with the ostial position. Now, whether to put one more stent or no was the issue, but we thought we'll put another stent. So this was another stent which was placed at the ostium. And it was post-dilated with an NC balloon 4.5. This patient actually went home and was on dual antiplatelet therapy and oral anticoagulation. And 1 month later, he came back with severe chest pain, gross resting depressions, and hypotension. And you can see everything wrong with whatever we had done. The stent has got clot. The clot is extending into the proximal or ostial LAD as well as the circumflex. So the entire left circulation looks very, very difficult. Fortunately, the blood pressure was reasonable, though there was a lot of tachycardia and heart was struggling. So we decided we'll put one more stent because we have some reasonable experience. This is another case where we have a left main distality, distal mid and distal half of left main is showing a critical narrowing with hardly any flow to circumflex as well as LAD. So this was stented, and at this time we have taken a stent into proximal LAD, and this established a good flow. You can see heart briskly contracting. So everything worked in this case with one stent towards LAD. So this is our past experience. And in this particular case, we put a balloon pump because there was hypotension and we are dealing with a very critical area. The both LAD and circumflex OM were wired, and multiple aspirations were done. So patient has a balloon pump, 2 wire in place, aspirations done. That is the story so far. And we thought we probably need to stent more towards LAD and accept some compromise to circumflex. The circumflex also had a sizable circulation. So this is the time we thought we must get the ostium correct. So this is our favorite view, the shallow LAO and steep cranial. Or you could do a small RAO, 5 or 10 degrees with cranial view. And this shows a good stent position. We're obviously not very concerned about the circumflex flow at this stage because it's probably the first stent is not across the mouth of the circumflex. So there was no sort of concern that there would be 2 layers of stent at the mouth of circumflex. So this was a 4 into 28 length stent which was deployed. So we are covering the earlier 1-month-old stent, and we are covering the circumflex ostium, going well beyond the ostium into proximal LAD. And this was a 4.5 NC dilatation at high pressure, covering the ostium. We, of course, use a stent boost when we are doing this position. And this time, of course, we are very confident that we have got the ostium correct. So we will make the stent float out and do a high pressure inflation. So part of the balloon is outside into aorta, part at the ostium. And when we want to withdraw this balloon, this is a point I want to make, that the guide stent is at the ostial location. If you push the guide only on the wire, it could hurt the deployed stent at the ostium. So generally, we get the guide close to the deployed stent with the balloon inside, so that the guide catheter and balloon are sort of aligned towards the vessel, and it doesn't hurt the deployed stent at the ostium. So this is a care we take, and this is the final result we have good flow towards LAD right from the ostium. This time we have not missed the ostium. You can see ostium very well covered. And fortunately for us, the flows to the circumflex are also going well. So we didn't have to do anything special to the circumflex flow. On these occasions, you should probably choose a stent which would be very friendly with the, and there's no time. So if you have an occlusion of the side branch, like in this case, circumflex after putting left main to LAD stent, and you spend about 10 minutes trying to rewire and establish flow, a lot of harm could be done. So this is an onyx stent keeping a flow well to the side branch. And this is the final result. So issues here are, why did the patient have thrombosis? I mean, left main was stented. The first one, the stent ended before the origin of the circumflex. And as I discussed, probably we missed the ostium and had inflated high pressure balloon, 4.5, going to very high pressure. And that probably was the reason for the thrombus. But it took good 1 month. I mean, the patient was home on dual antiplatelet therapy for 1 month before he came. So in my mind, I still have some reservations as to whether he had a sort of issue with tricaglor. So that was another thing which we changed. After doing this, we change him to prasugrel. Tricaglor resistance is very unusual, but not unheard of. I think people do talk of tricaglor resistance also. So that was another thing at the back of our mind, and we changed from tricaglor to prasugrel with this final result. This was our first presentation, thrombus in the left main. I think the cath lab image intensifier clearly shows this kind of thrombus, though it is not very well here. So this is after the first left main stent. We have probably missed the ostium. This is how he presented 1 month later. He was taking all the tablets that we had given. So he was on tricaglor, aspirin, and warfarin, and yet he had this thrombus. And this is after the second procedure where stent is going beyond the circumflex origin into left, into proximal LAD. So this is how we had a problem with the thrombus. Any comments? Any?
Hello, sir.
Dr. Prabhakar, anyone for that
Yes,
matter.
sir, I just wanted to ask a few questions, sir. One thing, we have seen similar cases where we have this free-floating thrombus in especially young people. And we have given tirofiban infusion in such cases, and we had very good results with those. But yet there was some residual disease. Is it good to stent those cases with that minimal plaque or minimal residual disease which is there after tirofiban infusion? That is one
working in Ruby Hall, I would always do imaging on this. I think since it's an osteal lesion, probably IVUS would be better than OCT to image this. And that would tell us whether we have, in addition to thrombus, some kind of cuts in the left main. If that is there, I mean, we are talking of fissure versus
plaque rupture versus erosion.
Rupture, yes.
Yes.
And then if it is a rupture, of course, we like to stent. If there is no rupture on imaging, then this may be left unstented. But it's left main. I would really be very hesitant to leave anything just like that. And I should have I think we missed the ostium. That was probably the biggest fault in this case.
And regarding, because I've seen many senior cardiologists putting these patients on anticoagulation also, sir, along with antiplatelets.
No, he was on anticoagulation. He was on ticagrelor, aspirin plus warfarin. I mean, there is a big risk when you give these three together. And but then he was a very understanding gentleman, so we didn't mind giving him 3 anticoagulation. Though, of course, if he had kind of any kind of bleed, he would have jumped at our throat. I mean, you should be ready for that. Dr. Prabhakar or Dr. Girish, any comments on
No,
this?
I think fantastic case, and it's a very dangerous location. I feel, sir, we could have missed an ostium, but also it's so much thrombus burden. It's very difficult to be precise. And why he stent failed could also be because of such large thrombus burden. And also, we are skeptical of doing thrombus aspiration in that location because oftentimes a small dropping back of this into the aorta can cause cerebral strokes. So oftentimes, what I do is I just image once, and if that is okay, I directly stent. At that time, in that location, long-term outcomes are secondary priority, but try to get the best.
No, 1 minute,
safety.
Dr. Girish. I mean, despite having a thrombus like this, you would do a direct stenting, correct?
Yes.
And you would expect the thrombus to stay between the stent metal and the vessel wall and not distally embolize.
No, the whole idea, sir, is the risk of stroke, because if all the thrombus aspiration trials, only drawback was the strokes, especially if it is something dangling in the ostium of the left main. We are sure to embolize some amount every time we fiddle something. So if it is distal embolization, I'm not concerned, but if it's a proximal embolization, we are worsening the patient. And that's
What
a young
we
boy.
do is the guide catheter has to be very, very well aligned with the vessel. Like this is the lie of the left main. The guide catheter has to be absolutely in line. I mean, the vessel
coaxial
and the guide catheter should be absolutely coaxial. If that is correct, I think your thrombus aspiration catheter would do a good job. Also, the back end should be on negative. So a strong negative all the time, all the way out. I think if we do this, we haven't had a single time we have faced a brain embolism during aspiration. I think we are very.
This is my collateral understanding from, if there's a very proximal LAD large thrombus burden, you start aspirating, invariably there is some chunk that goes into the circumflex. There is proximal migration of the thrombus and some fragmentation that goes down. So we're sure it may not have gone to the brain all the time, but there is always a risk, sir. So
no, yes, I mean, we have one case where the thrombus went to circumflex. But I think good negative, strong negative at the back end, all the way out. I think till the aspiration catheter comes out of the groin, I think maintain that negative. Because so many times you see a thrombus sticking to the tip of the aspiration catheter.
Yes.
As it is coming back into the guide catheter or going through the groin sheets, it can slip out. So good negative is very, very important at this time.
Very sure.
Sir, actually, I have a lot of comments on this case. The point is, the first time when you did the angiogram, you showed a very, very thrombotic lesion there.
This is the one.
The first angiogram, the other view that you showed, looked like something was really hazy there. There was a real clear haziness. It could be most probably a thrombus. And what could be the cause without any other disease in any other place? It's just the isolated left main alone. The rest of the vessels are looking clean. So probably some kind of a dissection. Now you tried a thrombus aspiration, probably underlying dissection leading on to this kind of a problem. That's one.
Actually, this gentleman was playing football when this happened.
So
I
ruptured
don't
is
know
part.
whether that can connect with what you're telling us.
So what I felt was when Dr. Girish discussed the case in the first point with you, he said, I will stent it. Now, was it sensible to wait on a left main thrombus, such big thrombus with tirofiban and heparin, and we can just plaster the thrombus with a good stent, and you have a gap between the bifurcation, ostium, and then go ahead and get it done. We had an ostial miss, but that can happen to anywhere. But you felt that at that point, angiographically, it looked good till the second shot you took. And then again, you try to put another stent and then you did a high pressure inflation. Now, if the stent had an ostial miss and you had a high pressure inflation, so there is going to be a dissection proximally and producing a thrombus that is going in. And you have covered it beautifully with the triple antithrombotics. You're going to have warfarin also, despite all the risks involved, not recommended that much as a triple antithrombotic, and with the aspirin, ticagrelor, and warfarin. The risk of bleed is high, but still he develops a thrombus. So clearly there is a pharmacological failure. Or the second point is, this is probably a dissection and there is an edge dissection at the distal end that we have missed, because the thrombus is actually from the edge of the stent, in the distal edge of the stent, going into the LAD. So probably there was a distal edge dissection that led to a thrombus that has probably gone into the LAD. So there is definitely, this is the view I was telling you about, sir. So something really dancing there. And why not just get a wire into the circumflex LAD, just take a stent and plaster the whole thing? Why wait for this? And if he had gone in for a progression of the thrombus,
This is when he has come back after 1 month. Okay.
There's no stent there, sir. I think this is the first one, right?
This is first one?
Yes, sir. Because you see the thrombus there. The first one.
Okay. This is first one.
That's exactly the view. The previous view was the one that I was talking about. You have a small area, take a floppy wire, just get inside there, get a stent directly, stent it. That's it.
So the lesson is left main, never take a chance.
Don't take a chance, because you would have lost him.
Yeah, I mean, even if it is a thrombus, the thrombus will get plastered between the stent and the vessel wall in this location.
Yeah, and we keep doing this. I think we discussed in one of the other meetings. Go for an inflation and then deflate slowly, so that you don't pull the thrombus by a sudden deflation. Come down on your deflation a little slowly, not too fast. Left main, it may be tricky, but I think you have to probably get it done a little
Even
slowly.
inflation also, I think you can quickly go to about 4, but from 4 to maybe 25 or 30, go slow. I think that is one way in which you don't disturb the thrombus too much, you know. And deflation, of course, deflation going slow is not an issue. You can easily go slow on deflation.
And the osteal lesion, the other thing I felt was, first time when you had the problem and you thought you had missed it, you want to put a second stent in the ostium. If you feel like doing it, probably a floating wire in the left main would have probably guided you to keep a stent there in position. Maybe. No, it's all retrospective thinking, sir. At that point,
but
I think you don't have time to think.
Yes, I think it's you can get a guide wire out of the guide catheter
at
and
sinus.
let it loop at the
sinus,
in this aortic sinus, not enter into the vessel wall. And that is how you can exactly judge the off-shell position.
That is another point. And I think the rest of it, I think you have demonstrated clearly. But with the triple anticoagulation, what do you think is the pathology? Is it probably a distal dissection, or where did the thrombus come from when the patient is on dual antiplatelet with warfarin?
Well, I think if he has resistance to ticagrelor, that's a possibility. I mean, we don't generally have it. I mean, we don't generally think about it. But I feel this was also a possibility.
Now, I totally agree with you there, sir, because resistance to prasugrel is probably not known, and probably the least among the three. The choice of changing from ticagrelor to prasugrel, I think, was pretty obvious in this particular case.
So what is your sort of, say, 100 cases you do? How often you use ticagrelor and how often you use prasugrel?
Sir, after the Prague game, I kind of literally shifted to prasugrel. But the problem was availability of prasugrel. I had one fellow who stopped prasugrel and he shifted back to the original brand of ticagrelor. I thought it's better for the patient to take dual antiplatelet than so. This guy stopped the thing and came back to me luckily in 2 days. Then I realized that the availability of prasugrel is a big problem. So then I moved it. Actually speaking, that is my only problem. Otherwise, after the Prague, I
No,
really
but there
Prasugrel.
are so many Indian brands of prasugrel available today.
Not as freely available as Ticaplat, sir.
Is it?
Definitely, sir. At least here I've had a little bit of problem because Ticaplat is so freely available, and that now that it has come down and off the price thing and it's off the patent, Ticaplat seems to be much more freely. Even there, I prefer the original brand at least for the first 3 months, and patients don't complain of the cost. And I tell them it's going to be for a short time, and sometimes push it to 6 months, and then after that it really doesn't matter much. In this case, actually, it's such a large stent, and when you have a left main thrombus there in the left main, within a stent, there has to be some problem like a distal dissection. I still feel that, unfortunately, we don't have an imaging to say that, but I think there must have been a problem there, the distal part, which was not visible angiographically. I don't think it's just a guess, sir. Girish, sir, you're nodding your head. Go ahead. You unmute yourself and talk, sir.
The
always
style
guessing.
in which we deploy the left main stent is deploy at maybe 6 to 8. Bring the balloon back, so part of the balloon is hanging outside, and go high on pressure. So we probably did that, and I don't know if you missed the ostium, it could probably hurt the ostium, and that could be one of the reasons why it sort of got into a thrombotic situation.
But I think that the disease was more in the body mid and the distal part of it, isn't it, sir? More than the ostium of the left.
No,
Came back.
it was in the ostium. I will show
I think
you
the first picture I think it shows, the one on the left, I think shows some kind of a osteal thing also. I didn't notice it initially. But in that case, I think we'll have to call it as a pharmacological failure or probably a dissection there that is promoting a thrombus there.
So we corrected both. I mean, we put an additional stent and we change him from tracheal to prasugrel.
Yeah, that's the best that can happen. Young guy, but we still need to work on his, procoagulant state, and we don't know if he had a dissection also there, or just the thrombus. When you look at the angiogram.
I mean, this is the view before the first stent went in. So it could be a dissection too. So left main, see, it is so, I mean, one could have missed the thrombus in the first. See, this is all that you see when you take a first picture. And
caudal views.
Yeah. But then this is the view which tells us that, yes, it is. I mean, I've rarely seen so much difference in 2 angles, but I think, yes, we must understand why we take multiple views.
The other point about hurting the ostium of the stent proximal part of the stent in the ostium, wherein you keep a wire and the balloon and go ahead with that. Will it help if you inflate the balloon, push it on the balloon like what we do with the Guidezilla, and then get the guide catheter inside, sir?
Yes.
I think that would be more useful since you have a balloon there at the ostium.
Yeah, absolutely.
Push it along with that. I think it goes straight into without damaging the ostium of the.
Yeah, that is what I showed in this presentation too, that with the wire and balloon inside, you advance the guide catheter towards the left main, so that you're well inside a roomy left main. The guide catheter is floating well aligned with the rest of the left main.
See, the greatest challenge is rewiring without going between the stent struts and the wall. When we have covered the ostium of the stent, ostium of the left main. And the bigger challenge is recrossing into the side branch through the center of the stents. I think that's where having this balloon in the left main and taking the guide into the middle of the left main and then take the second wire. That's how it probably helps you to avoid go between the stent struts and the vessel wall. Great case. Plenty of them.
Plenty of learning points. Lot of new information. Lot of learning points. The failure of why it developed a thrombus and how you can miss the ostium, how we could get the ostium, and then getting into these struts and then getting another stent inside, covering the whole thing. I think excellent case for discussion, sir.
I always, when I suppose my fellow has started the case and taken some initial picture, when I go and join him, I ask the nurse if she has given Tricaglor 2 tablets. I don't ask the fellows because I think it's the nurse's job. And so many times the fellows, they may or may not ask whether 2 tablets of Tricaglor are given or no. So I think these are some issues, I think, which though we may be working at a higher level, you must make it a point to do it yourself. All right, Mr. Ravi, looks like
Yes, sir.
any other comments, Dr. Prabhakar or Dr. Girish?
Actually, the other thing is if the time is short and when you are so thrombotic, Ticaplat is going to take time to act, about 30 to 40 minutes to act. You can probably give 1 bolus of tirofiban there, just the bolus dose.
I
That
think
also
now
helps.
we have Dr. Cangrelor.
Yeah.
So this we have made it available in the cath lab. The beauty of this is when you suspect a left main, a patient may go for a bypass surgery. Cangrelor, the effect is just over in next 1 hour of stopping it. And we have it on the shelf these days. That's a great addition that has
probably
happened
less
to
than
us.
1 hour also. Like you stop Cangrelor, the action is steeply down. So in next few minutes, the action is gone completely. So I think this
So that's
is
a great
another
addition.
yes, I think we must think of it.
And another thing, what has been my practice is giving loading on the table. I think is more documented than Ticagrelor. So if I have not given a bolus and then I decide to do an ad hoc and load the second antiplatelet, I always prefer Prasugrel than Ticagrelor because the studies are on the cath lab.
I think that's what the European guidelines are also said. On-table loading, I think, has to be Prasugrel.
No, why the action is quicker than Ticagrelor, or?
One, it's quicker, sir, and the data is more in favor of Prasugrel. The European guideline on ACS in NSTEMI came up and said that if you're going to load there, the immediate data is better with Prasugrel.
So you continue with Prasugrel afterwards?
You continue with Prasugrel, sir.
Yes.
Oh, that's a news to me. I did not know that immediate use is better with Prasugrel.
Because when we compare the Ticagrelor and Prasugrel, the clinical trials, the Prasugrel was mostly given on table, sir, not in the ER. And Ticagrelor was given in the ER. So when you look at that, I think we should, if you extrapolate that data on the table, I think Prasugrel looks much superior to Ticagrelor.
No, but it's so easy for us, like a patient who is not on any antiplatelet and he is with you. You do an angiogram. So some patients you give Ticagrelor and measure platelet inhibition percentage at the end of, say, 1 hour or half hour, and do the same with Prasugrel. And that will tell us whether action is quickly on or no. Mr. Ravi, you have anything on this issue, since it is the onset of action that we are talking?
No, sir. There is no comment from any delegates as so far.
All right, we'll call it a day and close today's session. Thank you all for joining us. And again, Emcure plays a very crucial role in bringing all of us together on these exciting meetings. Thank you, Ravi. Tell all your colleagues that we are really, really obliged.
Thank you, sir. Thank you so much. It was really a fantastic day today, sir, because we witnessed almost 470 students was present today, and it was really a nice case presentation done by Dr. Sajid Kishan as well as Dr. Agarwal. Thank you so much, both of them, and also thank you for a very unique and interesting case that will be definitely very important. Once again, thanks to our moderator, Dr. Prabhakar Singh and Dr. Krish sir, for joining us today. Once again, thank you, Sri sir, for this event. Thank you, sir. Good day, sir.
Hey, Karki, Lara.
Thank you, sir.
Thank you, sir. Good night, sir.
Good night. Good night.
Good night.
Good night.